Apoorv Mittal. So his talk will be AMI with triple vessel disease, PTCA for IRA only or non-IRA only. Also, I'm sure it will be, he will say mainly IRA.
Dr. Chauhan, on the left is your timer. Kindly pay attention. Thank you.
Good afternoon, everybody. Respected chairpersons and dear friends, I'm here to discuss role of PTCA in triple vessel disease in acute ST elevation MI, infarct related or non-infarct related artery, both. Introduction. Primary PCI is now the treatment of choice for patient with acute ST elevation MI when it can be performed expeditiously by the experienced team. The goal is the restoration of flow within 90 minutes of presentation to a PCI equipped center or within 120 minutes from time of first medical contact. And this strategy has been found to be superior to thrombolytic therapy in improving morbidity and mortality. In patients presenting with ST elevation MI, multivessel coronary artery disease is found to be present in around 40 to 60% of patients, and presence of multivessel coronary artery disease is found to be associated with worse prognosis in patients with STMI. An identification of optimal strategy for treating these patients is a subset of considerable interest and controversy. So we have three treatment strategies in acute STMI with multivessel or triple vessel disease. The first one is the aggressive approach, that is acute multivessel PCI during STEMI. Second is conservative approach, that is acute PCI of infarct-related artery alone. And intermediate approach is acute PCI of infarct-related artery followed by stage PCI of secondary lesions. And if we look the data, then in the real practice, single vessel disease occurs in 45%, single vessel disease PCI, and primary PCI of infarct-related artery, that is conservative approach in around 20%, aggressive approach in 20%, and stage PCI in around 15%. So coming to the aggressive approach, that is acute multivessel PCI. This is a case example of 52-year-old male chronic smoker presented with acute anti-wall MI with cardiogenic shock, and patient when we do the angiography, the patient have a LAD, there is a tight 95 to 99% blockage in the LAD proximal with TIMI2 flow, and second there is a ramus tight blockage of 90% ramus proximal, and RCA it is CTO 100%. So first of all, as it was an anterior wall MI and LAD was an infarct related artery, so I revascularized the LAD, and in spite of revascularizing the LAD, with door to balloon time of 30 minutes. But even after the revascularization of LAD, patient continued to have hemodynamic instability. Patient was on IABP, still patient continued to have BTVF. So I revascularized the ramus in the same sitting, and after that patient have improvement in the symptoms, improvement in relief of chest pain, vitals become stable, and therefore it become an indication for multivessel PCI. Clinical studies supporting, some of the clinical studies supporting multivessel PCI in STEMI, some of the non-randomized registries, and these are single center registries which favor multivessel PCI, and these registries showed that it causes decrease in major adverse cardiac event as compared to the conservative approach. And another registry by Regetri et al. Showed that primary PCI alone has better early outcome, culprit vessel, whereas multivessel stage PCI tends to better long-term outcomes. And even from the randomized studies, some of the randomized studies have shown that multivessel PCI decrease in hospital death, repeat revascularization, and rehospitalization. These are another studies with larger number of patients, which showed that even in non-cardiogenic shock patients, multivessel PCI decreased 30-day mortality, and another by Kong et al. Showed that multivessel PCI decreased in hospital death. But Chen et al. There was pitfalls in these studies as they have taken very stable patients for the multivessel PCI, and when they have taken unstable patients also, as in Chen et al., there was no difference in mortality or combined death, MI, CABG or TAVR. So what are the advantages of acute multivessel PCI during a STEMI? It causes complete revascularization, it treats ischemia at distance, it treats unstable lesions, and patient feel more comfortable having a complete revascularization. But disadvantages, there is increased risk of contrast-induced nephropathy as more dye was used, increased radiation exposure. There is a complications of treating additional lesions may be fatal. Acute MI is a prothrombotic and inflammatory state, and complications will be more in treating the stable lesions, and there will be increased risk of stent thrombosis, and many times acute STEMI has a coronary spasm associated with, and there will be overexaggeration of the lesions. Coming to the conservative approach, it's a 50-year-old male, chronic smoker, presented with acute inferior valve MI with window period of 4 hours. And when we do the angiography, it showed that RCA was 95 to 99% blocked with TIMI2 flow, and there was a occlusion in the LCX proximal also with 80 to 90%. So we do the revascularization of the RCA with door to balloon time of 20 minutes. Patient become hemodynamically stable. There was no chest pain, and we leave the patient only on the RCA revascularization, and we leave on the medical management, and patient is doing well. So conservative approach, there are more robust data with the conservative approach, and many studies favor that conservative strategy is better than the multivessel and stage PCI. And this is a randomized study of 502 patients showed that multivessel PCI increases reinfarction, revascularization, and major adverse cardiac events. Similarly, this is a New York PCI registry which reported that in stable patients with multivessel disease, acute multivessel PCI results in increase in hospital mortality as compared to the conservative approach. And in another study, randomized study also, acute multivessel PCI shows increased mortality. This is a US National Cardiovascular Data Registry of around 29,000 patients, which showed that not only in cardiogenic shock patients, but in overall STEMIs, multivessel PCI cause increase in hospital mortality as compared to the single vessel PCI. And this is a randomized study of multivessel PCI, of conservative approach versus stage PCI, and 1:1 randomization with early FFR guided PCI versus conservative therapy after treating of the infarct related artery. And it showed that in 48% cases, non-culprit vessels have no reason to go for angioplasty as FFR was more than 0.75. And when we treat that another 52% of the patients, then still there is no difference in LVF and major adverse event at 6 months, but it unnecessarily increases the cost to the patient. This is a meta-analysis of 9 non-randomized studies and 2 randomized studies, which shows that as compared to multivessel PCI, conservative approach is better, and MACE and long-term mortality are similar. So what are the advantages of the conservative approach? Treat only culprit vessels, avoid complications associated with treating other lesions, non-infarct artery PCI only when objective evidence of ischemia is present, and in future we can discuss risk and benefits. But disadvantage may leave behind significant ischemia producing lesions, may not prevent recurrent ischemia. Patient have to return to laboratory routinely. Coming to the third approach, that is the intermediate approach, acute PCI of infarct related artery followed by stage PCI of secondary lesions. This is a 61-year-old male diabetic hypertensive presented with anti-valve MI, window period of 6 hours. The LED shows 95% blockage with TIMI2 flow. There is a tight blockage in the OM branch, OM proximal branch around 90%, and RCA was non-recessive. So we revascularize the LED with door to balloon time of 30 minutes with 1 triangulating stent. Patient become hemodynamically stable. We wait for another 2 weeks, but patient continue to have angina on exertion. So we do the repeat angiogram after 2 weeks. We show that LED stent is patent, but there is a persistence of the tight blockage in the OM. So we revascularized the OM branch also, and now patient is doing well. So this is a randomized trial favoring intermediate approach, which is found to be superior to the conservative approach with proven silent ischemia after STEMI. And this is a trial presented in TCD-MD, which showed that stage PCI is better than the multi-vessel PCI and that is conventional approach, and it is associated with lower short-term and long-term mortality, and multi-vessel PCI among all these three was linked to highest mortality rates, and the best strategy in patient with cardiogenic shock remained uncertain. What are the advantages of intermediate approach? We can optimize potential or complete revascularization, and we perform the PCI of stable non-culprit lesions more safely at later phase after stabilization. Disadvantages may treat asymptomatic lesions, complications of treating secondary lesions early after index event, and timing of stage PTCA is still uncertain. So, in conclusion, what are the reasons which support multi-vessel PCI? Plaque instability may not be limited to the culprit lesions, may involve larger area of coronary tree. Complete coronary revascularization is known to be associated with better long-term prognosis, and patient preference, patient may feel more comfortable when going home after complete repair. But disadvantages are much more with acute multi-vessel PCI, as STEMI is not an ideal situation for dealing with stable stenosis. There can be a presence of diffuse coronary spasm. There can be presence of multi-valve PCI, increases risk of contrast-induced nephropathy, increases risk of radiation exposure. There is no objective evidence for non-infarct artery PCI, and PCI complications in stable lesions may be catastrophic, as STMA is an extremely prothrombotic and inflammatory state. And this is an example, this is a study which showed that in acute MI there is non-culprit lesions, there is exaggeration of the lesions, and this is an example that 45-year-old presented with inferior STEMI, but there are some borderline lesions in LAD and this OM branch. We revascularize the LAD with 2 resolute stents, and after 2 weeks we do the FFR, and we see that FFR is more than 0.75, and the lesions which were appearing tight are now appearing non-critical. So you may end up in putting more stents at the time of acute STEMI, so we should avoid treating non-culprit lesions in these scenarios. But there is marked difference from literature to real life, as there is absence of simplification as they have shown in randomized controlled trials. The role of CABG in multi-vessel disease after STEMI is never investigated. They can be present of 2 to 3 unstable infarct-related arteries, and there can be 60 possible clinical and angiographic scenarios. So ideal randomized controlled trial to address this issue is unlikely. So how to address them in clinical practice? We should try to follow the conservative approach, and we leave the patients on medical therapy, and if patient remain asymptomatic, stress test is negative in follow-up, and there is no evidence of silent ischemia after STEMI, we continue to maintain on medical therapy. If we follow the intermediate approach, if patient continue to have symptoms, patient have positive stress test, or there is evidence of silent ischemia after STEMI. And aggressive approach is only justifiable in patients with presence of multiple critical more than 90% lesions and potentially unstable lesions. Briefly about role of CABG in patients with multi-vessel disease, and it is important treatment in patients with triple vessel disease with left main disease, anatomy not suitable for PCI, diabetes with triple vessel disease, and extensive calcification of coronary arteries. And this is an example of 74-year-old diabetic CKD patient presented with acute inferior wall MI. The vessels were highly calcified, and infarction is because of the shutdown of the PLV branch. There is tight occlusion of the left main, there is tight occlusion of the LAD proximal, LAD mate is 100% CTO, the tight occlusion of the LCX. So we stabilize this patient, manage conservatively with IABP support, and we send for urgent CABG after stabilization, and now patient is doing well. So what do guidelines recommend? ACC guidelines recommend that PCI should not be performed in non-infarct artery at the time of primary PCI in patients without hemodynamic compromise.
Dr.
European
Chauhan,
guidelines
sorry
suggest
for the interruption. We'll just
that
a minute.
single vessel PCI should be a default strategy. Acute multivessel PCI can be justified only in exceptional patients with multiple critical and potentially unstable lesions, and significant lesion of non-infarct artery should be treated either medically or staged revascularization procedure. Both options are currently acceptable. To conclude, approach of triple vessel disease in acute MI is to be individualized. Single vessel acute PCI of infarct-related artery in STEMI should be a default approach. Acute multivessel PCI only in presence of cardiogenic shock or when multiple unstable lesions or multiple critical stenosis. Stage PCI only in presence of persistent symptoms or with objective evidence of myocardial ischemia. Many of the patients with acute MI with triple vessel disease are subset for emergency or urgency ABG. Thank you.
Thank you very much.